Welcome back, everyone. Today we are diving into one of the most elegant examples of engineering in the human body, the Palmar Arches. It is the plumbing of the hand, and believe me, it is way more than just some tubes in your palm.
Exactly, Dr. Khan. From an academic standpoint, the Palmar Arches are a favorite for board examiners because they represent the perfect anastomosis. We are talking about the primary collateral circulation that keeps your fingers alive even when you are gripping something so hard you are cutting off half the blood supply.
I love that. Think of it like a dual-source power grid for a city. If the main power line on the east side, the ulnar artery, gets crushed, the west side line, the radial artery, is already looped in to pick up the slack instantly. But Sarah, let us get precise. Which artery is the lead actor for each arch?
High-yield fact number 1. The superficial palmar arch is primarily a continuation of the ulnar artery. It enters the hand lateral to the pisiform bone through the canal of Guyon. The deep palmar arch, however, is primarily formed by the radial artery after it ducts through the first dorsal interosseous muscle.
Right. The radial artery is the one that takes the scenic route. It goes around the back of the thumb through the anatomical snuff box and then dives deep like it's trying to hide. But why does this matter clinically? Well, imagine you're a carpenter holding a heavy hammer all day. Your palm is constantly compressed. If you only had one artery supplying those digits, you would have ischemic blue fingers by lunchtime.
And that is why the location of these arches is so specific. The superficial arch lies just deep to the palmar aponeurosis, but superficial to those long flexor tendons. The deep arch, true to its name, lies right against the bases of the metacarpals. It is protected by the tendons.
It's like having a backup pipe buried under the floorboards while the main pipe is just under the carpet. Now, Sarah, when students see this on an exam, they often get tripped up on the branches. What should they look for?
Focus on the digital arteries. The superficial arch gives off common palmar digital arteries, which then split into proper palmar digital arteries for the sides of our fingers. But here's a board favorite. The thumb and the lateral side of the index finger. They usually get their blood directly from the radial artery via the princeps pollicis and radialis indicis arteries before it joins the deep arch.
That is a huge point. The thumb is so important, it gets its own dedicated supply lines. Now let's talk about the Allen test. This is the bread and butter of clinical hand exams. If you want to be the doctor of choice for your patients, you have to master this before you even think about putting an arterial line in someone's wrist.
The Allen test is essentially a real-time stress test of this anastomosis. Dr. Khan, why don't you walk us through the why of the procedure?
Gladly. You have the patient clench their fist to pump the blood out of the hand. Then you use your thumbs to compress both the radial and ulnar arteries at the wrist. When they open their hand, it should look pale, like a ghost. Then you release just the ulnar artery. If the hand turns pink within 5 seconds, the palmar arches are patent. The ulnar artery is doing its job and can support the whole hand if the radial artery is compromised.
And for the boards, remember that a negative Allen test means the circulation is normal. If the hand stays white, that is a positive test, meaning the collateral circulation is inadequate. You would never want to harvest the radial artery for a heart bypass or perform a radial puncture in that patient.
Exactly. You are checking if the safety loop is actually connected. We see this in trauma all the time. Lacerations to the palm can be absolute nightmares because of these arches. Since it's a loop, a single cut can bleed from both ends. It's not enough to just clamp one side. The backflow from the other artery will keep the party going.
That is a great clinical pearl. The pressure in these arches is quite high because they are so close to the major terminal branches of the brachial artery. Another high-yield anatomical relationship is the median nerve. The median nerve travels through the carpal tunnel, deep to the flexor retinaculum, and ends up just deep to the superficial palmar arch.
So if you are a surgeon and you're releasing a carpal tunnel, you better know exactly where that superficial arch is sitting. One wrong move and you have a very bloody field. It's all about layers: skin, palmar aponeurosis, superficial arch, then nerves and tendons.
To wrap this up for our listeners, let's summarize the big takeaways. Number 1, the superficial arch is mostly ulnar. The deep arch is mostly radial. Number 2, these arches allow for uninterrupted blood flow during heavy gripping or manual tasks.
And number 3, always perform an Allen test before any procedure involving the radial artery to ensure that beautiful collateral loop is actually working. The hand is a tool of precision, but it only works if the plumbing is perfect.
Perfectly said. Knowledge of the palmar arches is the difference between a successful procedure and a very cold blue hand.
Thanks for joining us, everyone. Keep studying the why behind the anatomy, and we'll see you in the next episode.